My name is Aisha Mergaert, and I'm a senior at Knox College, and my talk is called Global Health from All Perspectives. So my main focus as a biochemistry major with a minor in anthropology sociology is to find a way to improve global health, primarily by examining the connection between science and clinical application. Through my experience in India and Scotland, I have learned that good science does not always lead to good or improved health. This conclusion was mainly fostered by my independent study in India, as well as my experiences in Scotland. While in India, I researched the National Tuberculosis Control Program, focusing on its successes and failures at controlling TB in India. So India carries a third to a fifth of the global TB burden, meaning that India is disproportionately burdened with TB. In India, TB kills more people than any other communicable disease, so we're talking more than HIV/AIDS, more than malaria combined. So it is a really serious problem. And part of the reason that it's such a serious problem in India is due to the conditions of poverty and overpopulation. TB is spread through the air when you cough or sneeze or even spit. And if you live in a very confined space or if you're malnourished, you're at an increased risk of developing tuberculosis. And this has really been a problem in India for many, many decades. But it really hasn't been until the 1990s that they've really saw any progress. So to do my research, I focused on using tax, government resources, non-governmental resources, analysis by the World Health Organization, etc., as well as interviews with TB experts and other public health experts. So the National Tuberculosis Control Program was started in 1962, but very, very quickly after, as early as the early 70s, it was found to be really insufficient to meet the needs of India and the tuberculosis crisis. And part of this was because they had an over-reliance on X-ray diagnosis. When you get tuberculosis, you form scars in your lungs, and X-ray was used to visualize those scars and determine whether or not you had tuberculosis. However, this is really insufficient because TB can have scars that you can't see on an X-ray. You can also have scars from the incidence of TB that you had a long, long time ago. So they were pulling people out of the population for treatment who didn't necessarily have TB, or were missing people who did. So that was a serious problem. There's also problems with short-course chemotherapy or short-course treatment. This is a treatment strategy that's been around for a while where you give people a cocktail of drugs a couple times a week for as long as 12 months. And this can result in some really serious negative side effects. And that results in some non-compliance because people feel sick and they would rather have TB than have the side effects of the drugs. Additionally, getting to clinics can be a really big problem. If you're poor or mobile, a rickshaw ride may be your wage for the entire day to get to the clinic. So it's an important consideration. So in order to kind of combat this problem, directly observed treatment, short course, was developed, DOTS, by the World Health Organization in 1993, and very quickly adopted by India because clearly they really needed it. And this is exactly the same as normal short course treatment, except this brings your treatment into the home. So instead of you having to go to the clinic to get your medication, someone from the program, someone from the clinic would come to your house and they would watch you take the medication every single time you needed to take it. And this really increased compliance and increased oversight for patients. And what this does additionally is it decreases drug resistance with tuberculosis. You may have heard that drug resistance is a really huge problem, and if people don't comply with their medications, it develops really easily. Something that happened really quickly with this is that non-compliance was reduced and drug resistance was also reduced. So another change that we made to the program was introducing the sputum through microscopy in place of X-ray diagnosis. And what this does is it tests for the bacterium in the sputum, meaning that you're taking the people who are absolutely most infectious to the population and giving them treatment and really suppressing the bacteria. And that's really safest for everyone. And compared to X-ray diagnosis, this is a much quicker, more cost-effective way of diagnosing people, and it also requires much less training. So I think it's a really excellent example of how science can be really used effectively in the field to really help public health. So I also came to some other conclusions about solving the TB crisis in India. First of all, really increasing public awareness of TB and its pathology, Also increasing physician education. Physicians don't always know how to treat tuberculosis. And in that regard, they also need to communicate better with the tuberculosis control program because they know what they're doing, and they also need to keep their patients in line with the program. And in general, poverty needs to be combated. If you improve housing and nutrition and access to general health care, you'll really, in the long run, decrease tuberculosis incidence. So after I went to India, I studied abroad at the University of St. Andrews in Scotland, and there I took an infection and disease module, which was generally an overview of disease pathology, not just neglected diseases, but also other diseases. But we did have some focus on tropical disease. So during those periods, was really allowed to explore drug discovery and development and get to understand the process by which a drug is taken to market. And through this, I found some problems that science has with really seeking the needs of the world. Through this, I really understood how drugs get funded. They're really more funded by the needs of the developed world and not by the developing, meaning that the consideration of the thousands and millions of people who are sick with things that are a little more serious than some of the things we may be dealing with don't get any attention. Additionally, when you're developing a drug, I learned that it's really important to think about things like refrigeration. If you're working in sub-Saharan Africa, you probably don't want a drug that needs to be refrigerated if you need to be out in the field. And also with tuberculosis, it would probably be better to have a drug that can be administered once a month or once a week instead of a cocktail of drugs that you have to take every other day. And doing that can really change the course of public health. So, after experiencing such a broad range of ideas relating to global health, I came away with some poignant conclusions. First of all, I learned that through my experience that science is really only as useful to health as its ability to function within the social context. And second, I learned that the needs of the developing world need to really be expressed more, and I've kind of decided that as my future career goal, that's really what I want to focus on. I want to be a research scientist, and I want to focus on neglected diseases, and really try to change this. Thank you.